Okay guys, so let's discuss the next topic that is about the types of calcification. So first of all, what is calcification? When there is the calcium deposition in our body, that is called calcification, and when this calcium is going to deposit it in our body, the tissue will looks like basophilic. So basically this basophilic is mainly because of calcium. When on the tissue the calcium is going to be deposited, that tissue will look basophilic on hematoxylin and eosin stain. So this is the staining method which is used to see the tissues which has a deposition of calcium. So then after that we have the two type of calcification. One is dystrophic and the second one is metastatic calcification. So first of all, you guys have to remember the basic difference between the dystrophic and metastatic. So let's take an example. This is the dystrophic calcification, and on the right side we have the metastatic calcification. You just have to remember two things. First of all, we have to understand the serum calcium level. What is the level of serum calcium in both these conditions? In the dystrophic calcification, the calcium is going to be normal in your blood. It means the serum calcium is normal, but the tissue which is going, the tissue in which the calcium is going to be deposited, that is the abnormal. So here the serum calcium is normal, but the tissue in which the calcium is going to be deposited, that is abnormal, and this abnormal tissue will try to, you can say, will try to call the calcium. The calcium will come and deposit on that abnormal tissue. This type of this type of calcification is called dystrophic. Then after that we have the metastatic calcification. In metastatic calcification, your blood calcium is going to be increased, and your blood calcium is more, but the calcium which is going to deposit it on the tissue, those tissues are normal, those tissues are not diseased. So this is the basic difference between the dystrophic and the metastatic. So let's take a quick review from the first aid. They say the calcium is going to deposit it and on the tissue, and that tissue is abnormal, that tissue disease in the dystrophic calcification, and it tend to be localized. It like here they mention the example of calcific aortic stenosis, like the calcium is going to specifically deposit in the aorta, and then that can lead to the aortic stenosis, and that aortic stenosis is because of calcium. This is called calcific aortic stenosis. Then what are the conditions that are associated with dystrophic calcification? Like if a person has the TB, in the TB you get the calcification of lung and the pericardium. Then other granulomatous conditions. Then in the liquefative necrosis of chronic abscesses, fat necrosis, infarction, thrombus, cystomeiosis, congenital cytomegalovirus, toxoplasmosis, rubella, Psammoma Bodies, Crush syndrome. Then we have the atherosclerotic plaques. Then all these are the conditions which are associated with dystrophic calcification, and atherosclerotic plaques can also become calcified because these plaques will again attract the calcium. So these are the associated conditions. Then what is the etiology? So basically due to injury or necrosis, your let's suppose if your tissue is going to be injured, that injured tissue will again will, you can say, catch the calcium. When that injured tissue will catch the calcium is going to deposit it. So this is the etiology. Then after that we have the metastatic calcification. Basically in this the calcium is going to deposit in the normal tissue. Your serum calcium is more, but the tissues are normal, and again in this the tissue is going the calcium is going to be deposited in widespread fashion, in diffuse fashion. That is not specific, that is not localized. So please keep this in mind. In the metastatic calcification, the calcification is going to be widespread. It involves the multiple systems, it involves the multiple tissues. Then what are the associated conditions? Like predominantly the calcium is going to be deposited in the interstitial tissues of kidney, in lung, gastric mucosa, because these you can say tissues loses acid quickly. So the tissues which loses acid quickly, their pH is going to increase, and when the pH is going to increase, that increased pH will favor the calcium deposition. So they can ask from you in exam, why in the interstitial of kidney, why in the lung, why in the gastric mucosa calcium is deposited more? So the reason is these tissues will love to lose the acid quickly. When acid is losing quickly, it's mean the pH is going to be increased. the pH is going to increase, it will favor the calcium deposition. Then after that, you guys have to remember one thing, when the calcium is going to deposit in the collecting duct of your kidney, it is called nephrocalcinosis. And when you get the calcium deposits in the collecting duct, your ADH is not going to work in the kidney. So when the ADH is not going to work in the kidney, that will lead to nephrogenic diabetes insipidus. That is not central, that is nephrogenic, because it is a problem in the kidney. Then after that, it can also lead to renal failure, because when the calcium is going to deposit in the collecting ducts, your collecting duct will not function normally, so it will lead to renal failure. So these are the associated conditions. Then after, in which condition you will get the metastatic calcification, like if the person has CKD. In the CKD, what will happen? In the CKD, your phosphate is going to be accumulated in your blood. So when more phosphate in the blood, your calcium is going to less. So when the calcium is going to less, the PTH is going to produce in more. When the PTH will produce more in your body, the calcium is going to be more. It will lead to hypercalcemia. So that's why they mention here the example of CKD. In the CKD, it will lead to hyperphosphatemia, and the hyperphosphatemia will lead to secondary hyperparathyroidism. That secondary hyperparathyroidism will lead to secondary hypercalcemia. Then after that, the hypercalcemia from other causes, like if the person has primary hyperparathyroidism, if the person has parathyroid adenoma, hyperplasia, or the tumor of parathyroid. So if the parathyroid tumor is present in your body, that tumor is going to produce more PTH. The more PTH will lead to the more calcium, that will lead to hypercalcemia. Then we have the sarcoidosis. In the sarcoidosis, we also know that there is large amount of production of calcium. Then hypervitamin D, if you take the vitamin D more, that will lead to increased amount of calcium in your body. So these are the examples, or these are the causes in which you get the metastatic calcification. Then after that, we have the Psammoma bodies. So what are Psammoma bodies? Basically, these are the concentrically mean it looks like this, concentrically arranged laminated calcified spherules. So what is the meaning of spherules? Basically, these are in the form of spheres, and in the like this, if you get the calcification, it is called, like if these are the concentrically arranged spherules, and on those spherules you get the calcification, it is called calcified spherules. So this is the definition. What are Psammoma bodies? These are the concentrically laminated calcified spherules. And in which type of tumors you get the Psammoma bodies? This is very important MCQs. You guys have to memorize this. The papillary carcinoma of thyroid gland and kidney, somatostatinoma, meningioma, mesothelioma, ovarian serous capillary cyst adenocarcinoma, milk prolactinoma. In these conditions, you are going to get the Psammoma bodies. In your body, the proteins are going to be arranged in concentrically in laminated fashion in the form of spherules. So when you see the histology, you will see the calcium deposits in the basophilic color. Basophilic meaning blue. So when your tissue is going to when the calcium is going to deposited in your tissue, that tissue will look basophilic under the histology. So this is about the Psammoma bodies. Then after that, we have to understand the ionizing toxicity. So first of all, you guys know this thing. When you are going to get the ionizing radiation, I already explained in the free radical injury, these ionizing radiation are going to damage your tissue. How these radiation are going to damage your tissue? Basically, they are going to produce the ionizing free radical. So these free radicals are going to damage the DNA. So ionizing radiation causes DNA double strand break and cellular damage, both directly and indirectly, to the production of free radical. So when you are getting the ionizing radiation, after the radiation in your body, they are going to produce the free radical. These free radicals are going to damage the DNA and also cellular damage that can be directly or indirectly. Then there are different kind of complications that can arise after the radiation, but these complications depend on the dose of the radiation. If you are getting the more dose, the more complication will occur. If you are getting the less dose, the less complication will occur. So here they mention complication usually arises when the patient is exposed to significant doses, when the patient is going to expose to more doses. So here they give the example radiotherapy, nuclear reactor accident. So these are the examples in which you get the more radiation. Then after that, we have the complications of the ionizing radiation. There are localized complications like inflammation and fibrosis can occur. Then also leukemia and thyroid cancer. In thyroid cancer, you will get the papillary thyroid cancer after the ionizing radiation. Then after that, what is acute radiation syndrome? Basically, it is the you can say the complication of radiation that usually develop after the ionizing radiation when you are going to expose your whole body under high doses of ionizing radiation. Then after exposing the body under high doses, you will get the nausea, vomiting, diarrhea, hair loss, erythema, redness, cytopenia, headache, and altered mental status. So these are the collection of symptoms which are collectively called syndrome, and you are getting this after the radiation, and that radiation you get you can see in acutely. So that's why it is called acute radiation syndrome, and it usually develop after the you can say sudden exposure of ionizing radiation. So that's why it is called acute. Then they can ask from you in the exam like what are the tissue that are going to be damaged more during the ionizing radiation injury. So basically these are the stem cells of regenerative tissues like skin, bone marrow, GI tract, and gonads. These are the more susceptible to radiation injury. You guys have to remember this. Then after that, the radiotherapy damage cancer cells more than healthy cells because the cancer cells have dysfunctional DNA repair mechanism in the addition to high replicative rate. So the question is basically they can ask from you in exam why the radiation is going to damage the cancer cell more than healthy cell. Basically the cancer cell don't have the DNA repair mechanism very good. So if the DNA repair mechanism is not good, so it's mean your cell is going under death, because if you not repair the DNA, your cell will undergo death. Then after that the cancer cell have a high replicative rate. So this is also another reason those cells which have the high replicative rate, the radiation is going to be effective more. So over tissue or over cells are not replicating more, and over cells have good DNA repair mechanism. So that's why over healthy cells are you can say going to be injured less. So this is the ionizing radiation toxicity. Then after that we have to discuss the another important topic that can also come in exam with the name of asthma. So basically from this topic I have to understand of the organs in our body that become ischemic very easily. So first of all, what is ischemia? Basically it is inadequate blood supply to meet the demand of the body. It is called ischemia. And how that ischemia will occur? Basically when you decrease the arterial perfusion in the example of atherosclerosis, when you decrease the venous drainage in the example of testicular torsion, Budd Chiari syndrome. So, and also if you get the shock, in all these conditions your body will not get the adequate oxygen, adequate blood, so your body will undergo ischemia. Then after that you guys have to remember the what are the organs, what are the regions in our body that are going to be more vulnerable to hypoxia and ischemia. So basically the brain, in the brain we have the region where the ACA, MCA and PCA are going to meet, like anterior cerebral artery, middle cerebral and posterior cerebral artery. The regions where these arteries are going to be meet, or you can say the regions where the branches of two arteries are going to meet, and those branches, those distal branches of the arteries don't have limited collateral vascularity. Those are called boundary areas or watershed areas. So please keep in mind what is watershed area or what is border zone area. Basically these are the areas which receive blood supply from the distal branches of two arteries, and these areas don't have collateral blood supply. So it's mean if they don't have collateral blood supply, they are going to be injured more. And what are the regions where these watershed areas are present? So these areas are present where the anterior cerebral artery is going to meet with middle, and the middle is going to meet with PCA. So this is the important example. Then in your heart, like the subendocardium of the left ventricle is going to be injured more. Then in the kidney, your proximal tubule segment, straight segment of the proximal tubule in the medulla, then your thick ascending limb of loop of Henle in the medulla. These are the two organs which are more vulnerable to hypoxia and ischemia. Then in the liver, the area around the central zone which is called zone 3 is going to be injured more. Then in the colon, the splenic fracture which is called Grift point, and the rectosigmoid junction which is called Sedgwick point. So these are the areas which are going to be injured more. Then this is the definition of watershed area which I already explained. Watershed areas are receive blood supply from most distal branches of two arteries with limited collateral vascularity. So basically what is watershed area? These are the areas which receive blood supply from the two arteries distal branches. Like let's suppose these are the two arteries, and these arteries are giving these distal branches. So these distal branches are going to, let's suppose, feed this area, the star area. So this star area is called watershed area. But the problem is that this watershed area is not having they're not having any collateral circulation like from this side. So it's mean if you damage these distal arteries branches, so this area is going to be ischemic, or you can say this area is going to get more hypoxic injury. So that's why they mention here. Then these areas are susceptible to ischemia from hypoperfusion. If the less blood is going to your brain, the less blood is going to your brain, it's mean hypoperfusion. Then neurons most vulnerable to hypoxic ischemic insult, including the Purkinje cell of cerebellum, pyramidal cell of hippocampus, and neocortex. So these are the examples, you can say, in which the cerebellum, you can say the cells of the cerebellum, or the, you can say, the cells of hippocampus or neocortex are going to be injured more. So they can ask from you in exam, please mention the cells of cerebellum which are going to be injured more. Please mention the cells of hippocampus and neocortex that are going to be injured more. So pyramidal cells of hippocampus and neocortex, Purkinje cells of cerebellum, these are the cells which are going to be injured more. So these are the, you can say, the important topics you guys have to prepare from the first aid. Okay guys, so let's continue the next topic, that is about the types of infection. So basically, first of all, you guys have to understand how many types of infection. There are two types, like one is red infection and second one is pale infection. So here they can ask a question from you from this kind of infection, like what are the organs or under which conditions you will get the red infection and the pale infection. So first of all, red infection is going to occur when there is the venous occlusion in our body, and second, the red infection is going to occur in those tissues which has multiple blood supplies, like liver, lung, intestine, and testes. This is the second, you can say, the cause of red infection. And the third reason is the reperfusion. So these are the three main causes which will lead to red infection. First one is the venous occlusion, second one is the tissues which have multiple blood supplies, and the third reason is reperfusion, especially after the angioplasty. And a reperfusion injury especially lead to red infection by producing the free radicals, which we already discussed in the previous topic. Like when you are giving the blood after the, you can say, after the angioplasty, when your blood is going to the area which is ischemic, then that blood will produce the different kind of free radicals, and those free radicals will damage the tissue, that will lead to red infection. So these are the, you can say, the important points which are related to red infection. Then after that we have the pale infection. So first of all, you guys have to understand same, in which tissues or in which causes you will get the pale infection. So first of all, the pale infection is going to occur in solid organs. Solid organs means those organs who have like single blood supply, like single arterial blood supply, like the heart and kidney. So heart and kidney have the single arterial blood supply. So these organs are going to get the pale infection. So these are the types of infection which you guys have to you can say remember. Just remember the causes, and after that try to memorize the reasons of a reperfusion injury, like how the reperfusion injury is going to damage or causes the red infection.